Acute arterial occlusion. Acute arterial occlusion is the sudden interruption of blood flow which may cause complete or partial obstruction of the artery. Critical ischemia of the extremity develops and may result in loss of affected extremity and or death. Pathophysiology and etiology. Embolization is the most common cause of acute arterial occlusion. Emboli may consist of thrombus, atheromatous debris, or tumor. Emboli most commonly originate in the heart as a result of atrial fibrillation, MI, or congestive heart failure, about 85%, but can also occur after invasive procedures such as cardiac catheterization, angiography, and surgery. Arteriosclerosis may cause roughening or ulceration of atheromatous plaques, which can lead to emboli. May also be associated with immobility, anemia, and dehydration. Emboli tend to lodge at bifurcations and atherosclerotic narrowings. Other causes of acute occlusion include trauma, thrombus, venous outflow obstruction, which includes compartment syndrome. Clinical manifestations. The patient may experience acute pain and loss of sensory and motor function due to emboli blocking the artery and associated vasomotor reflex. It causes paralysis of the part, anesthesia of the part, pallor and coldness, edema, rigidity of the extremity. Diagnostic evaluation. Neurovascular assessment of affected area. Assess for acute severe pain, assess for gradual acute loss of sensory and motor function, and check for aggravation of pain by movement of pressure on the extremity, palpate for loss of distal pulses, inspect for pale, mottled and numb extremity, inspect for collapse of superficial veins due to decreased blood flow to the extremity, inspect for sharp line of color and temperature demarcation. This may occur distal to the site of occlusion as a result of ischemia, and assess for edema. Doppler ultrasonography, segmental limb pressure and pulse volume recordings may indicate decreased flow. Radionuclide scan may indicate clot. Arteriography confirms the diagnosis. Digital subtraction angiography and MRI may be done for cerebral embolization. Management: drug therapy, anticoagulants, thrombolytics. Surgery: embolectomy must be performed within 6 to 10 hours to prevent muscle necrosis and loss of extremity. Fasciotomy: incisions made over leg compartments to aid expansion of edematous tissue and relief of the pressure on the arterial system. Amputation of affected limb is if revascularization is inappropriate due to metabolic complications. Treatment of shock and bed rest. Complications: irreversible ischemia and loss of extremity. Metabolic complications are acidosis, hyperkalemia and renal failure. And third complication is shock. Thank you.